opportunity to speak with you all. I'll be discussing the challenges of surgery in austere regions using my volunteer experience in northern Gaza as an example. I have no relevant disclosures, of course, but as a warning, I will be sharing some graphic images. So obviously, the situation in Gaza is very dynamic. So these graphics are just to provide some context to when I was there in December of 2024. At that time, all aid and humanitarian missions were entering Gaza Strip through the south at the Charleston crossing. And as you can see in this graphic here, this red line is essentially the Netzarim crossing, which was extremely restricted access between the north and south of the Strip. So even for humanitarian missions, there's really restricted access there. My team, our destination was Gaza City here in the north. I would also like to point out that Gaza City was also separated from the further north region with really only limited medical evacuations being allowed to exit northern Gaza, where the Mallah hospital was functioning in a very limited capacity at that time as it was under siege. The hospitals that me and my teammates worked at were these three facilities in Gaza City: Al-Shifa Hospital, Al-Ahli Baptist Hospital, and Perlmutter Hospital. Al-Shifa Hospital was at one time the largest tertiary center in the Strip, and at the beginning of the war as well functioned as the main receiving hospital for injured patients in the north. After the near destruction of Al-Shifa Hospital in March of last year, Al-Ahli Baptist, which is a very small private hospital, essentially took over that role. And the public aid hospital has some operating capacity, and so we were performing some operations there as well. These are some photos of the Al-Shifa complex. So this is the surgical specialty building, which was a 6-floor building that had ORs, 20 ICU beds, interventional cardiology, radiology suite. These are some images that anybody who's worked anywhere in the operating room would recognize some of these materials and equipment here. Unfortunately, I think this video was not functioning when we tried it earlier. But I was in one of a select group of people, unfortunately, due to the limited access to the north, and even fewer people who actually went to work in Shifa who were able to see it. This one, you can see, was the destruction of some of the operating rooms, which were obviously rendered non-functional. At the time that I had gone, there was reconstruction happening at that time, and they had opened the emergency room, or a new, smaller emergency room was open in this building. This is where we were working. This video also not working. About 20 emergency beds, and they had been able to convert 2 dental procedure rooms into functional but limited operating rooms, where smaller procedures, wound agreements, and actually there's some thoracic surgery procedures there as well. This was where they were trying to rebuild an area for inpatient beds. They also had a small laboratory and blood bank. This was our method of transportation between the 3 hospitals was via ambulance. As you can see, all the ambulances we went by had been attacked at some point and had gunshot wounds and bullet wounds, but the hospitals were all between a 5 to 10 minute travel via ambulance. This is Ahli Hospital, which, as I mentioned, was a small private orthopedic hospital, but after the destruction of Al-Shifa Hospital, really took on the major role of being the main receiving hospital for patients that were injured. This is the hospital that had the only functioning CT scanner in the north. As you can see here, this is the emergency room. It's quite small, had 12 beds, and they had an additional 4 beds that had monitoring capabilities. This hospital had 3 ICU beds and 3 operating rooms, and they hadn't had an additional one by converting the recovery room to an additional operating room. And all of the staff that were here were staff that had worked at Sheffield Hospital, and after the reopening of the emergency room at Sheffield Hospital, essentially all of the staff rotated between these 2 hospitals. As this hospital was mainly an orthopedics hospital, however, any general surgery procedures were not performed here. So any patients that needed laparotomies or thoracotomies had to be transported to the public aid hospital to have their operations done, unless they were having a concomitant orthopedic procedure. So as you can imagine, transporting acutely injured and critically ill patients was just a major challenge for us. Just to add some context about the injury patterns that we saw, these are just some pictures of what the surrounding area in Gaza City looked like. Very different from the South, where there are large tent cities with tens of thousands of tents and makeshift tents. In the North, people were living amongst the ruins of destroyed buildings, living in partially destroyed buildings. You see evidence of that everywhere. Curtains and clothes in the middle of destroyed buildings. And this is just an example of what was also seen all over town: completely collapsed buildings. This, I was told, was a 16-story building before. It's just kind of helpful in contextualizing the pattern of injury that we saw. So the vast majority, actually all of the patients that I took care of really were polytrauma patients from explosions, which were, and when you say explosions, they're essentially airstrikes on buildings. So these patients all had a combination of penetrating trauma from shrapnel, blunt trauma from crush injuries, and burns. And like I said, this was a slightly different injury pattern from what I'd seen at previous experience working in the South, but these were all the patients that we were getting had these injuries. And we also dealt with the sequelae of these injuries. This is an example of a shrapnel injury. These were very large pieces of shrapnel, very different from things that I've dealt with before. It's extremely large emissions. You have very large pieces of metal, very large pieces of building material causing penetrating injuries. This was shrapnel that was taken out of this child's chest wall. And as an example of kind of coordinating care, this child came in a mass casualty event, brought to the FICS hospital, was intubated, and then in order to have her operation, we had to go take her via ambulance to the public aid hospital. She was unable to be extubated due to her severe pulmonary contusions, and since there's no ICU beds there, we had to transport her back to the FICS hospital to be placed on a ventilator. So obviously, transporting critically ill patients is complex all the time, but the vast majority of these cases are happening at night, and so there's the additional difficulty of the increased risk to patients and healthcare workers traveling at night when airstrikes are more common. These are just some additional examples of the kinds of shrapnel injuries that I was treating as a general surgeon, doing, mainly treating thoracotrauma injuries. So more examples of the kind of crush injuries and polytrauma that we treated. This is a leg of a child, obviously unable extremity. This patient also had polytrauma to her major vascular structures and her chest and abdomen muscles. Ultimately did not survive. These are just some additional examples of the type of crush injuries and burn injuries that we saw. Multiple kind of traumatic amputations in addition to shrapnel injuries. This was just very common. These were, like I mentioned, in addition to the acute injuries, we had to deal with the sequelae of these injuries. So very common to have chronic wounds and wound infections. This is a lower extremity of the patient, obviously with an external fixator and a large chronic wound. This is a patient who was dealing with complications from having been trapped under a collapsed building and had severe crush injuries to her thorax. She required bilateral orthopaedics for deportations from hyenas and obviously a large chronic wound. I was not part of her operations, but just been trying to kind of help with her care. But probably the most common operation that I actually did was orthopaedics and deportations from hyenas. It was extremely common. So just in summary, a big challenge is the fragmentation of care was really difficult. Not having a center or hospital where we could provide kind of the comprehensive acute trauma care and manage patients operatively without having to transport patients is obviously not ideal. Lack of essentially everything. Those of us who work in low resource settings often are familiar with not having adequate facilities, equipment, medications, working in substerile conditions, having inconsistent access to water and electricity, but the scale of it was on a completely different level here. Limited staff. I put burnout in quotations because I don't think that's an adequate word to describe what the staff are really have been experiencing, working in incredibly intensive settings for day in and day out for over a year and a half, while also experiencing everything that the rest of the civilian population is experiencing. Every staff member that I talked to had a story of displacement, had a story of losing family members. There are multiple documented attacks on healthcare workers themselves. I treated healthcare workers that were injured. I worked with healthcare workers that were injured. Another important factor is that the vast majority of the staff are incredibly young and relatively inexperienced. Most of the physicians that were working in these emergency rooms are general practitioners, so they've completed medical school but have not done residency. And covering both the Shifa Hospital and the Mallah Hospital, there was only one attending emergency physician supervising all of this care. And then of course, in terms of surgical outcomes, population-wide factors such as malnutrition, inadequate water and sanitation facilities, inadequate shelter contribute to wound infections, poor wound healing. Not to speak of, obviously, they're contributing to the spread of communicable diseases and the worsening of chronic illnesses. And then I have a list because I could literally speak for hours for some of the different challenges. So, in the interest of time, that's my 12 minutes.
Thank you very much. Eye-opening. The next we'll have Dr. Michael, is it Samatoka? Samatoka, speak on the war in Ukraine. Thank you very much for your patience.
If there anybody in the room that's bothered by disturbing slides, I talk also as actually the room full of disturbance as I'm communicating. I'm ethnic Ukrainian American. I speak Ukrainian, I speak Russian. I was a full-time trauma medical director, resigned that position just to locums work now, and travel to Ukraine frequently to NGOs to do trauma training and trauma critical care. And the talk that I'm going to give to you is basically about what is going on in Ukraine, what the situation is. So it's my privilege to work with the David Knott Foundation from London. I am the faculty lead for trauma surgery training in Ukraine. I'm also on the board of directors for Med Global and the lead trauma surgeon for training trauma in Ukraine. This is just a picture of the current situation. In yellow are the territories that the Ukrainians have taken back from Russia. In red and pink are those that are still under control by the Russian army. Note that that area in red and pink is all farmland, and if in any type of a peace negotiation it is surrendered to Russia, it allows Vladimir Putin to control a substantial amount of the food supply to Asia and Africa. And so this is one of the areas of contention in terms of a final peace just settlement. So very briefly, I'm going to speak about tourniquets, the proper application, the length of their use, the role of our NGOs and the volunteers, trauma care, education and training, governmental bureaucracy, which is always a problem everywhere, antibiotic use and the use of best antibiotic is proper debridement and good wound care, then the lack of adequate staffing, and what's actually started and still drives this conflict. So for those of you who are not aware, and I'll try to stay as apolitical as I can, but Patriarch Kirill, who's the director, the Patriarch of the Russian Orthodox Church, was a documented KGB agent during Soviet times, has advocated for the continued battle and invasion of Ukraine. This is actually the 24th time in history that Russia has tried to wipe out Ukraine from the face of the earth. And if you just read what's in yellow here, hopefully this video works.
Многие из вас не вернутся завтра из боя, но не должно быть список ваших свидетелей и страх. Солдаты Божьей Родины, защитите православие нашей великой Родины, матушки России. По ту сторону фронта засели прислужники сатаны. Прикрывая сильными словами церковь, либеральные ценности, равенство, демократия, они прославляют Антихриста. Не может быть пощады сатанистов, какой бы он ты какие признали, солдата, коррупции, нефтяк. Все они одно целое, порождение ада. Да не тронет рука ваша, направляя пулю или снаряд во врагов Господних. Вам говорят, что идет война России и наша. Нет, это сражение добра и зла. Наступило время Армагеддона, за которым последует страшный суд. Вы на правой стороне в этой битве, и Господь вас не забудет. Ведь бой вас ведет сам Мессия. Воинство Путина – это Божье воинство. С нами Бог, за нами Россия. Ни шаг назад. Победа будет за нами. Аминь.
That's what the Russian soldiers are told as they go into war. Don't turn back, go forward, and create this devastation. This is the worst war I've seen in the face of Europe in a long time. So let's go to what we can do as healthcare providers. We're going to talk a little bit about tourniquets. The TCC guidelines, which were developed during the Iraq and Afghanistan wars, really don't pertain to the war in Ukraine. In Iraq or Afghanistan, within an hour or less time from the time that you were injured on the battlefield, you were on the table in front of a board-certified trauma surgeon who knew what to do and was able to take care of you. In Ukraine, they do not have air superiority. Patients can be on the field for hours or days at a time before they can be safely brought back and brought to a stabilization point. And so downtime is a tremendous problem for the Ukrainian army. Proper indications and application, so we told everybody to put the tourniquets on high and tight. If you needed a second tourniquet, put a second tourniquet on, because in those wars that we had, Iraq and Afghanistan, somebody would be taking care of you within an hour. Positioning of the tourniquet, and then of course the quality of the tourniquets has also been a problem. So here, you'll see one patient, minimally injured lower extremities, no significant deformities. He did what NATO trained him to do, put on his tourniquets bilaterally, and this is what ends up happening. Bilateral high AKA amputation. There are thousands of patients like this. There was one case of a patient who actually urinated on himself. He was so afraid during the battlefield, he was not injured. Put his tourniquet on, ended up losing his lower extremity. This has led to a couple of problems: severe rhabdomyolysis, the need for dialysis for these patients. As far as I know, the longest case of a placed tourniquet is 16 days. Not 16 hours, but 16 days on a patient. This is from a museum in Kharkiv in eastern Ukraine. This is about 150 plus tourniquets, all of which have busted and malfunctioned during their use during the war. The only tourniquet that has never had a single case of breaking is the CAT 7. That is the only tourniquet we know, whether it's American, Chinese, Pakistani made, all have had some breaks other than the CAT 7. Ukrainians have started making their own tourniquets. I'm actually part of a research study out of Italy. We're looking at the strength and quality, comparing all the different tourniquets which are currently being used in the war. So you can see here in an example, place it high, place it tight. If properly taken care of, this patient could end up with a BKA on one side and a trans knee amputation on the other side. Unfortunately, that's not the case. Here is a proper example of well-placed tourniquets. Wounds are clean. In Mexico Hospital in Dnipro, Ukraine, is a military civilian hospital. There are 150 patients with extremity amputations in the ICU at any given time. And there are 4 orthopedic surgeons who take care of all those patients on a regular basis. Imagine the amount of injuries. Imagine every one of those patients can't go back to the operating room for a planned second look, third look, further debridement. They do the best that they can. They transport the patients back to second and third line hospitals, but there is a limitation. So we have to really start to rethink limb tourniquet conversion. Release at 1 hour. If there's no active bleeding, leave the tourniquet in place, but leave it loosely. Use pressure to control bleeding instead of tourniquets. And then the whole concept of damage control laparotomy was unheard of in Ukraine. And so the idea of not trying to do everything at once and end up with a high mortality for the patients is something which is relatively new. So there are about 80 plus different NGOs that function going into Ukraine. And one of the problems that we face is that these NGOs don't always work together. We're not very efficient. We are trying to improve that and coordinate our care and our teaching and our training. We had one NGO who was going to Ukraine teaching Raboa in a situation which is, in the best of hands here, Raboa is controversial now. But there's actually one, I won't name what university they're from, but they were actually going out trying to train surgeons to do Raboa. Here we are, the training. It takes 2 days to get in because you can't fly into Ukraine. So you have to land in Poland, Moldavia, and then take a bus. It's 2 days in, 2 days out. You can see on the left, on your right-hand side is Ahmed, a member of the Syrian charity, which helps where there's a large Syrian population in Ukraine. They've done a tremendous job helping the Ukrainians with training. And then we bring anesthesiologists, nurses, medics, and surgeons for the training. This is with Med Global, the other organization that I work with. So we do 1 day of intense training. You're basically following the asset course, and then we do a pig lab dissection. You're not allowed to use human cadavers in Ukraine. Again, it's a problem. Had the government allowed us to do that, we'd do a much better training course, but we're not allowed to. And with the David Knott Foundation, we have an artist who created for $500,000 a very anatomically correct, unbelievable. You walk in the room, you look at it, you think it's a real person, but it's a mannequin. We do a 5-day training course. This is a picture of one of our graduating classes. Many of our students can't show their picture. They can't have their picture taken because they still have family in the occupied territories, and there are multiple documented cases of family members being killed when their relative is identified as part of the Ukrainian medical community. So one thing that we have done right is the FACS exam training. Unfortunately, there's wide variability and inequality in the training. At any given week, you can get an ultrasound training course in Ukraine, but many of these or NGOs that do this have little or no follow-up. There's limited resources, and of course, it's all Starlink dependent. Here we are doing some of the training, and this is one of our students. He actually texted me in the middle of the night one night after we had done our training. He said, "Hey, I just diagnosed cardiac tamponade and saved the patient from what you did." So very proud of that. Now, let me go back on the slide. Okay, trauma surgery as a concept was unknown in Ukraine. What I do, 5 years of general surgery, 2 years of trauma surgery training. When you say trauma surgeon in Ukraine, they say, "Oh, you're an orthopedic surgeon." No. So now the Ministry of Health, Ministry of Defense, has partnered with the medical universities in Ukraine, and they're making trauma surgery as a separate specialty and fellowship training. At the start of the war, every surgeon became a trauma surgeon. Imagine your damage control laparotomy being done by an ENT surgeon or a breast surgeon. That's what we started out with. And no offense to anybody who's an ENT or breast surgeon here in the crowd. All the medical textbooks were in Russian because that was the policy in the Soviet system. We do have an NGO that translates all these books and lectures. Identifying the correct students that we're going to maximize our education from is also challenging. And what we found is that there's an enormous variability in skill set and experience. There's some superb trauma surgeons who do excellent work, and then there's at the opposite end of the spectrum. The other problem that we have is the World Health Organization, USAID, does not allow us to train military trauma surgeons. So we have to seek private funding to help with that, or we simply don't identify them as military surgeons when they show up in our classes. Just a pig lab, system deficiencies, government bureaucracy on both sides, on the side of Ukraine and its allies, very heavy reliance still on volunteers bringing in medical supplies and transport, and there is a risk of harm to medical staff and their families. The Russian army targets hospitals, ambulances, doctors, nurses, and especially if you're coming from the outside, from the West America, they will target you. This is Hudson Berry, former chairman of orthopedic surgery of Walter Reed, an outstanding friend of mine, no ethnic roots in Ukraine, and he's gone, I think, now 10 times to Ukraine to do teaching proper amputations. Here we are at the Krakow airport with a bunch of supplies, bringing in humanitarian aid, and then it ends up somewhere like this in a warehouse. Somebody who knows what they're doing has to open up every one of these boxes, sort all the medical supplies, and then direct it to the proper facility. You can just imagine how unbelievably inefficient this system is. This is some of the people that I had the pleasure of working with. This gentleman on the right in the blue jet is actually a PhD in chemistry. That didn't work out for him, so he went and got a degree from Harvard, does something with computers. He basically bought a warehouse and helps direct and fund the supplies that we get. His brother actually was on the cover of Guardian journal defending Bakhmut. So he has a vested interest. This is another one of our students. These are some of the boxes that we supplied, and that blown up, torn down building that you see behind you is actually a functioning hospital with an operating room. And it doesn't look that way from the outside. Unfortunately, because of drone attacks, many of the deliveries have to be done at night. This is fully supplied by volunteers. These are three incredibly brave, Dr. Beshley and the Subko brothers. They were at the frontline hospitals for 2 years straight, no break. And this hits home, this video, I will show it. On October of 2023, I was standing right there. This is from January of 2024. The Russian army, to demoralize the population, targets hospitals, targets healthcare professionals, and they're not little bombs that they're using. This just shows you the magnitude of what they're using. And then, of course, our hospitals have to be fortified and defended. System deficiencies. Overall, there's a shortage of manpower. Some nurses and physicians, as I said, have been at the front lines for 2 years or longer. Soldiers are sent back to the front lines, even when they have not fully recovered, especially from head injuries. I helped recover one patient in Jacksonville, Florida for 6 months. He had Brown support syndrome. Limited use of his left arm, his right leg, and he's back in the front lines fighting now. He cleared his medical pass. Not enough trained medics to fully support the operations. There are NGOs that are addressing this issue, and unfortunately, there's still reliance on the old Soviet system. The professor knows best. No matter what you learn, no matter what we go through in our courses, if your commanding officer says, no, we're going to do it the old way, the way we've done it for 50 years, that's what the surgeons have to do. So that's a real problem. Lack of adequate military medical facilities. Ukraine was actually de-escalating its medical facilities because they signed the Budapest Agreement, which guaranteed them safe borders. They didn't need to be prepared for war, and unfortunately, they were caught very flat-footed. There's been overall poor coordination with military and civilian hospitals, but that has dramatically improved over the last year. And there are privacy concerns. If I'm a surgeon at a frontline hospital and I operate on a patient, I can't find out what happened to that patient in the second or third line hospital. I don't know if I did something right or I did something wrong, if I need to change my practice. Nursing as a profession is incredibly under-respected. And so one of our programs with Med Global is trying to raise the bar, the quality and the respect that the nursing profession has. There's little... I will wrap it up. Recognition of physical occupational speech therapy. There's no respiratory therapists, and prosthesis services and rehab centers are limited. This is a mobile hospital. I'll skip the video inside to show you. This is one of the frontline stabilization points. Ambulances are targeted. They're now building bunkers and putting their entire operating rooms underground. And there's a company in the Netherlands which provides portable operating rooms that can be put into damaged buildings or underground that's being operating. And again, some of their techniques and some of the instruments that they've actually developed are amazing. There's about 1,000 patients like this who will need multiple complicated operations for reconstruction. There's an NGO dental front that works with all these people. Infectious disease, so it's being fought. It's battle in a hostile environment, prolonged downtime. You could have cases of 8 different antibiotics in 7 days because the patient went from one hospital to another to another. And they get what antibiotic we give them. There's low microbiology testing. There is essentially no infection protection control. There's a lack of clinical pharmacists. The country is trying to move toward Western European standards. There's still no formal reporting system. They use chlorine to stabilize their equipment and OR, and they recycle PPE. You'll see 10 different family members using the same PPE, which obviously is useless. And physician education for blood and blood products. Trauma surgeons need platelets, but they never ask for it. You ask them why? Well, because the blood bank never has platelets. You ask the blood bank, they say, well, the trauma surgeons never ask us for platelets, so we never have them ready. And so it's been my privilege during this time to truly work with some truly outstanding people at the zero-line frontline hospitals. And the future, great improvements have been made. We need better collaboration between the different NGOs. The government, the Ministry of Health and Defense need to continue establishing national SOCs and stronger coordination of the care of the system. And I thank you for your time. And I apologize for being
We're going to need to press on, and let's have, is it Ridwan, is it Shopside? Okay, thank you, Ridwan. We can make sure this slide presentation is ready. He's going to tell us about cross-training of surgeons during health crises such as the COVID pandemic. Please, sir, try to keep your talk to 12 minutes. Thank you. Is Dr. Sidloff here? Okay, great. And also Dr. Is it Hyder? Okay, perfect. So I think, and then Dr. Campos, or Ms. Campos? Here, okay, perfect. I think what we'll do is run through all the people that are actually here and showed up, and then if there's time, we'll do the video from Dr. Perlmutter. Okay?
Good morning, everyone, and many thanks to the International College of Surgeons and its leadership for the honor of presenting to you. This is a story that happened that has a lot of great lessons. So everyone remembers late 2019, hence the name COVID-19. In late 2019, information was coming from China, and if you remember, the second piece of information was coming from northern Italy of a major pandemic, infectious disease hitting those areas. So I had a lot of friends in northern Italy, in Milano. I called my friends at the San Raffaele Hospital in late December 2019. And these dates are very important to understand what happened, because I'm going to show you some dates. So I said, what's going on? They said, waves of patients are coming to all hospitals in Milano and northern Italy in short order, in short time. We are overwhelmed. We know these patients have a respiratory failure, but we don't know we know what to do, put them on ventilator, give them supportive treatment, but the numbers in short times are overwhelming. So at that time, in early January 2020, I was having a cup of green tea, and I came to the conclusion that we in the United States are going to have this. I came to the conclusion also that New York, where I am, will be the portal where this stuff will come to the United States, and that where I am in New York, the Bronx, will be hit hard. The Bronx is the poorest borough of the city of New York, the poorest part of New York. We have people, 12 people living in 2 bedrooms. So the idea of isolation is just a fantasy. There is no infection control in such environment. So, and I started thinking, I'm the chairman of surgery, so the way we are set up in our hospital, 16 surgical services, breast, trauma, orthopedics, all surgical services are under one chair. So what should I do? So here's what happened. The hospital responded. Now we're talking about, if you remember, the first outbreak was after a wedding in New York. After a wedding, it started spreading from that big gathering, the virus, and it came to multiple areas of New York. The hospital, my hospital, combined all resources of critical care. That means the surgical critical care, the medical critical care, so the surgical ICU, medical ICU, and anesthesia. So that was the first step. However, my hypothesis was that at some point we might lose some of this work to disease. At some point this work will not be enough. And at some point, even if it is enough in the beginning, it will be overwhelmed. So the idea came also that the governor of New York banned all elective surgery by law. So all of a sudden I had brilliant people, board certified, double board certified, breast surgeons, colorectal surgeons, bariatric surgeons, all kinds of surgeons who are not doing any work. And then I started thinking, what should I do with these very smart, very intelligent people? Send them home, furlough them, cut their salaries, right? So, and I started hearing from other hospitals laying off doctors, cutting salaries. Forget about private practice. Private practice, no money. So we started thinking in our department about cross-training to satisfy the need that we identified. So we put together a professional project of cross-training of non-critical care physicians, and in my case, non-critical care surgeons, to deploy as critical care surgeons in the ICU. Because otherwise, no bariatric surgery, no breast, no plastic. So the other thing, we thought about this not only as individuals, we thought about this as a system, as a project, as a process, how to do this safely and effectively for the patients. So we created a program, and here you see the dates. And remember, I told you at December 2019 to January, we started the education in March. Just to put this into perspective, the peak of COVID-19 in the Bronx was on April 6th. That's when we reached the maximum number of patients, multiple coding, multiple cardiac arrest in the ER at once. And that's when we reached the highest mortality. We, on April 6th, we increased our ICU by the largest percentage in the city of New York. We went from 16 beds ICU to 95 beds ICU. And we were getting blue patients and respiratory failure in waves coming. We had 2 trucks parked, refrigerator trucks for bodies, parked at the hospital because our refrigerators were completely full. So this gives you the timeline. So we started cross-training of surgeons to become critical care on the 23rd of March and concluded a crash course on the 31st of March. The frontline deployment was for 5 weeks from April 20 to May 23rd, 2020, and they were tiered teams of surgeons, residents. We had PAs. The Department of Surgery had about 100 personnel between PAs and Ps, surgeons, residents, and we provided 24/7 supervision and support by senior critical care specialists. So we had tiered teams that we put them together to achieve the goal. The content of the training was from the Society of Critical Care Medicine, and this is the website. They had a special modules for education, and we had didactic sessions. We had, after the didactic sessions, we had training and shadowing and then deployment. This shows the actual schedule that was done day by day of education and didactic sessions, and then we handled also the issue of credentialing and malpractice insurance. So we provided liability coverage for those surgeons as they were deployed for critical care. So 17 non-critical care physicians participated, not a small number. And they were trained and served as frontline critical care in the ICU and in the intermediate critical care units. I'm very proud of this picture. In this picture, you can recognize myself standing there. With me to my right is the lady surgery chief resident. Next to her is our colorectal surgeon. This gentleman here is our colorectal surgeon, fellowship trained at Memorial Sloan Kettering Hospital and Mount Sinai Hospital, 2 fellowships, double board certified, not a critical care physician. This gentleman is our breast surgeon. He has been doing breast surgery for 20 years. You can imagine the anxiety of a breast surgeon doing breast surgery for 20 years, going to the ICU. This gentleman here to my left is the IT person. In the iPad here, this is very special. You can see in the iPad Dr. Lafaro. He is our cardiothoracic surgeon, and he is from the senior, generation. If today thoracic surgery and cardiac surgery are separated or separate. He is from the generation where they did everything from esophagus to chest to lungs to thymus to heart, and they did their own ICU. So the gentleman is the cardiothoracic surgeon, can run the ICU at the top level of critical care fellowship trained surgeons. He was our supervisor. This is a picture we're rounding in the ICU that we are in charge of. Remember, I'm a urologist. I'm far from critical care, and the breast surgeon and the colorectal surgeon and the surgeon chief resident. We took charge of a 12 ventilator unit. And we were supervised by the cardiothoracic surgeon. I'm extremely proud of this picture from that day. So the other thing we had a big group of orthopedics. We had 6 orthopedic surgeons. We had multiple orthopedic physician assistants, PAs. So what am I going to do with the orthopedics? Who is best at turning patients on fracture tables? During the time, we had 95 patients in the ICU. We needed proning, supining, without losing airway, without losing Foley catheters, without losing lines, central lines. And we created a team for proning and supining. They had daily rounds. They rounded every day. And they had requests from the critical care physicians. They ran into the medical circuit. There was no medical circuit. It was all ICU everywhere in the hospital. And just to put you in perspective, our hospital is 400 beds, 95 of them were ICU. And they did proning and supining. And I'm very proud of our orthopedic surgeons. I take also big pride. We did not lay off or furlough any surgeon or surgical resident or surgical PA or NP. Everybody worked, everybody was beneficial, everybody got paid their salaries. We did not cut any salaries in that regard. So, in conclusion, cross-training of non-critical care surgeons in critical care situations is feasible, effective, and safe if done as a project with multiple facets. Cross-train can be highly valuable. We lost a number of our original workforce to having COVID themselves, or we had one of our critical care surgeons die from COVID. God bless his soul, but this course came very handy. The theoretical education and practical training are both needed. The system of supervision is very, very important, and in this case we did tele-ICU, as you see in the iPad. Our cardiothoracic surgeon provided that, and our orthopedic surgeon did a brilliant service in proning and supining. We chronicled this experience in a book we published. The book was published by Springer Nature. You can find it on the internet, called Health Crisis Management in Acute Care Hospitals, Lessons Learned from COVID-19 and Beyond. Thank you.
Thanks so much. Next, we would like to invite actually a good friend of mine, Dr. Sidla, who's a trauma surgeon at San Joaquin General Hospital. He's also assistant professor of surgery at California North State University. He'll be discussing case-based analysis of surgical etiologies and interventions in the Gaza crisis zone.
yeah, my name is Boris Sidwell. I'm a trauma and general surgeon. Worked in Ukraine a few times, and I've also been in the Gaza Strip for some. So it's nice to be here with you guys. This is all my first ICS conference. So I'm going to talk about the Gaza Strip. I just got back from there on Friday, but this trip is...
Well, one second, we lost the projector.
Oh dear. I probably screwed something.
Just jiggle the HDMI.
Wiggle it.
There we go. Just wiggle. Just wiggle, wiggle.
I'll keep talking for the interest of time. So go for it. So yeah, unfortunately it takes about an hour and a half to explain what has been done in the Gaza Strip over the past, well, really 75 years, but especially over the past 2 years. But just to illustrate, the major book on the kind of recent political history of Gaza starts with the line, this book is not about Gaza, it's about what is being done to Gaza, and similarly so is this talk. But it's impossible to understand what the Strip, or what the Strip has become since October 7th, 2023, when obviously there was a major Hamas-led attack on the southern Israel, without understanding what Gaza was on October 6th that year. So just to summarize it, because we are short of time, Gaza is very small. It's about the size of metropolitan Philadelphia. It's the length of a marathon, it's the width of a quick jog, quite literally. Overall, it's more densely populated than Boston. The north is actually more densely populated than New York City, but obviously without the height of its great buildings or its municipal resources. It's also an incredibly poor territory, and very importantly, has been since what's called Operation Protective Edge in 2014. Most of Gaza, about 70%, is refugees. 250,000 of the Palestinians who were expelled from Israel when it was created in 1948 ended up in the Gaza Strip, overwhelmingly about 70,000 indigenous inhabitants of that area. It's also a very young place. It's among the youngest in the world. 50% of the population is under 18, and 15% of the population is under 5. It's a very, very young place. It's just impossible not to notice when you're there. Only 5% of the population is over the age of 60, so obviously very different from our own society. Gaza has been under what's called military occupation in one form or another since 1948, initially Egyptian occupation and now Israeli. The nature of the occupation is very well characterized by a standard history of the Arab-Israeli conflict by an Israeli historian, a pretty great guy actually, Benny Morris. He notes, and quoting, like all occupations, Israel's was founded on brute force, repression and fear, collaboration and treachery, beatings and torture chambers, and daily intimidation, humiliation, and manipulation. And he went on to note, and quoting again, the protracted state of political subjugation and economic dependence and the day-to-day realities of military occupation meant a continuous trampling on the basic rights and dignity of the inhabitants of the occupied territory. Israeli propagandists tried to project an image of an enlightened occupation, but in fact it was a brutal and mortifying experience for the occupied, as well as a brutalizing experience for the occupiers, the Israelis. Gaza has been subjected to a unique process in the world called de-development. The phrase was coined by Sarah Roy at Harvard's Center for Middle East Studies. She's certainly the world's leading expert on the Gaza Strip. She happens to be the daughter of Holocaust survivors. Anyone who wants to understand what this tiny and crowded patch of land was on October 6th of 2023 really should read the latest edition of her book. It's just entitled The Gaza Strip, Political Economy and De-Development. It's a crucial book to understand what this place was. Gaza is also blockaded during this time, which again is quite unique in the modern world. Since 2007, the Strip was under a land, sea, and air blockade. It's been in place for 19 years at this point. And this has had an enormously destructive impact on the standard of living, on Gazan society's ability to provide for itself the necessities of life, which was its openly stated purpose. So in summary, on October 6th of 2023, Gaza was a unique place. It was a compact, remarkably poor, incredibly young, highly repressed, occupied territory, subjected to economic de-development and outright blockade, a process that had played out over about 57 years, which is longer than almost anyone in Gaza has been alive. The large majority of the Strip's population has never known anything beyond the harshest phase of this history, the periodic Israeli military assaults that they can see listed there, and the blockade since 2004. If Gaza was unique before October 7th, now it's basically a different planet. According to the International Committee, or excuse me, according to the International Rescue Committee, Gaza is the deadliest place for civilians and aid workers in the world. This is pretty well reported on at this point in the lay press. According to UNICEF, Gaza is once again the most dangerous place in the world to be a child. I stress once again, that was the case in 2008 and 9 during the Israel's invasion called Operation Cast Lead. Is the case in 2014 during Operation Protective Edge as well. The rate of killing of children in Gaza is not well understood. In comparison to Ukraine, the rate of killing of children per capita per day is 330 times higher in Gaza than it is in Ukraine. It's quite a dramatic differential. And Ukraine was the worst country in the world for killing of children in conflict before October 7th, 2023. Gaza, since October 7th, has been the deadliest place for journalists in the world. In fact, there was just a publication a few days ago from Brown University showing that more journalists have been killed in Gaza than in all of World War I, all of World War II, the American Civil War, the Korean War, the Vietnam War, including Laos and Cambodia, and the entire war on terror. It's quite a differential. 86% of Gaza's landmass is currently a no-go zone. Actually, it's probably a little bit higher now because of the no-go zone in Rafah. Only the Mawasi is actually available to people to live in. Excuse me. And that's because Gaza has been physically destroyed, far worse than even Aleppo in Syria, Mariupol in Ukraine, or Dresden and Rotterdam during World War II. That's according to the Special Rapporteur on Housing. He said that more than a year ago. Gaza is the thirstiest place in the world, and by a huge margin. This is not a well-understood phenomenon. In October of last year, and things are much worse now, in October of last year, Oxfam reported that for the entire strip, there were 4.7 liters of water per person per day available. That's not just for consumption, that's for all uses, cooking, cleaning, bathing, etc. Currently, there are about 1.5 million people thought to be concentrated in the Mawasi area, that's the beach of Gaza. And according to Oxfam, that area has 121 toilets and basically no showers. There's no infrastructure there, if anybody knows. Well, 100% of the sewage and water plant sanitation system has been destroyed. The vast majority of housing, so estimated 92% recently, has been destroyed. 70% of sewage pumps have been destroyed, and the rest are offline because there's no fuel available to power them. Gaza is also one of the hungriest places in the history of the modern world, maybe the hungriest, but the recent data is not available, so I won't talk too much about that now. And Gaza is probably the most wounded place in the world, but it's hard to find comparative statistics, so I don't want to make a definitive statement. There are well over 100,000 seriously wounded people in Gaza. The number that's floated by the World Health Organization is that there's more than 1,000 pediatric amputees in Gaza, but I cannot imagine that's not an undercount. I myself saw well over 100 pediatric amputees just at European Hospital in the 2 weeks that I was there the first time. This time when I was back, it was even worse at hospital. And finally, Gaza has suffered, I guess, the most direct and sustained attack on a healthcare system that has ever happened. We just heard about Ukraine, and again, before October 7th, Ukraine was the worst place in the world for attacks on healthcare. Gaza is, like I said, it's just a different planet. According to there's plenty of peer-reviewed evidence on this now. For example, in the British Medical Journal of Global Health, I think it was February of last year, found no discernible distinction using satellite photography between attacks on hospitals and attacks on the rest of the territory. In other words, attacks on hospitals were just as likely as attacks on every other building. The the Office for the Coordination of Humanitarian Affairs maintains a project called the Humanitarian Data Exchange. And it includes attacks and killings of healthcare workers in both Gaza and Ukraine. In tiny Gaza is a place of 2 million people. Ukraine has 39 million people. And again, remember, Ukraine was the worst country in the world for attacks on healthcare before 2 years ago. In tiny Gaza, 2.4 times more healthcare workers have been killed in Ukraine. The per capita rate of killing of healthcare workers in Gaza is 110 times higher than in Ukraine. And the percentage of healthcare workers that are imprisoned is 200 times higher in Gaza than in Ukraine. And the rate of incidents, meaning the daily rate of incidents, obstructing or denying access to healthcare is 267 times higher in Gaza than in Ukraine. And I just want to emphasize I've worked in Ukraine. That's not to minimize what's going on there. It's to emphasize how severe the attack on Gaza actually is. So this is the trauma bay at European Hospital. You can see there really isn't much there. This is the different hospital that I just came back from. I just had time to do some presentations. few days ago. You can see there's basically nothing there. This is what we're working with in the Gaza Strip. So I went to, the first time I went to Gaza was with the Palestinian American Medical Association, and this time it was with Med Global. Both of them feed physicians, nurses, etc., into the what's called the EMT mechanism, the Emergency Medical Teams mechanism of the World Health Organization. And the WHO Constitution has 2 points that are worth pointing out here. One is just boilerplate. It's just the enjoyment of the highest attainable standard of health is one of the fundamental rights of every human being, without distinction of race, religion, political belief, economic, or social condition. We probably all agree with that. But the second is that the health of all peoples is fundamental to the attainment of peace and security, and is dependent on the fullest cooperation of individuals and states. I've always thought that was an interesting statement, especially the individuals part of it. So I'll just talk about one case. Normally I go through 3, but we don't have time today, so I'll just talk about this case. And like the others have mentioned, there are some pictures coming up. So this is a 9-year-old girl. Her name is Jury. Her father gave permission to show her face, so she was injured in an explosion 2 weeks before I met her. At that time, a femur external fixator was placed, and her wounds were closed primarily. You'll see what a terrible idea that was. So this is her when I met her. She rolled into the preoperative area for no reason that anybody could figure out. The nurse just said, "Can you do the case?" And I said, "I've never met this kid. Of course I can't do the case." What are you talking about? Well, what is it? And they said, "Oh, it's a debridement. Everything was a debridement." Didn't matter. So of course I said no, but then I looked at her and I realized she was dying. Her heart rate was about 170, her blood pressure was undetectable, she was completely altered. I actually thought she was 4 years old, she was so small. You can see the puffiness of her face, you can see the but you can the skin denting on her hand. It was quite clear that she had septic shock and was dying. I just didn't know why. And because, like I said, I'd never met her before. And so I looked around for her dad, couldn't find him, or mom. And so I said, well, she's going to die, so let's take her to the OR. We did manage to anesthetize her without killing her, which was a big win. And this is what we found when we turned around to her side. Most of us here are surgeons, and you're wondering who on earth did this to this kid, and not the mom, but the medical care. Well, the orthopedic surgeon that was supposed to be on call the day she came in was dead. And so the residents and med students had to do this case by themselves. They didn't know what they were doing, obviously. You can see that there's a giant dead flap of skin on her left buttocks. When we cleaned that wound up, the wound there was so bad that it cut down to her pelvis, exposing her issue there. Her left leg is completely destroyed. Her sciatic nerve is cut. She's missing about 2 inches of her femur. I have no idea how her SFA was attacked. It makes absolutely no sense to me, but she did have blood flow to her foot. Well, after several trips to the operating room and the work of about half a dozen surgeons, this is what her wounds look like, and they were definitely improving a lot. And as we got rid of the burden of necrotic and infected tissue, her sepsis resolved. She was able to eat again, things like that. There was actually still food available in Congress at that time, so she was able to eat and start healing. And you can see here, maybe you can't see it on this picture, but in this one you can see the leg length discrepancy. We had to shorten her femur so that we bring the gap in the soft tissues together. And you can see quite the leg length discrepancy that, like I said, was about 2 inches. So what is this again? Unfortunately, I can't talk about this other case just for one time. But these cases illustrate that the healthcare system in Gaza is massively overwhelmed, both by enormous needs and also by its direct destruction, like I mentioned. Like I said, the situation of the medical system in Gaza is completely and utterly and totally unprecedented. I was at Nasser Medical Complex until, like I said, just on Friday when I got back. I was actually almost killed there. I was on my way down to the men's surgical ward to change the dressings of a 16-year-old boy named Ibrahim Bahul on March 23rd. He had been injured in a bombing on March 18th. I repaired his colon, but it was kind of that borderline between a destructive and non-destructive injury at his intraperitoneal rectum. So I closed the injuries, but I also gave him a divergent colostomy. And by post-op day 5, he was actually ready to go home. So he was going to go home the next day. I was literally on my way down there when the Israelis bombed the room he was in directly. There was no mention, nobody planned anything else. The Israelis were very proud of what they had done. They boasted about it because they wanted to kill the other guy whose name was Ismail. They were from the same family, so he brought him moved at his room so that they could just have family time together more easily. Well, I would have been killed there. This level of attacks on healthcare is completely insane. It's the same exact thing, true everywhere, of course, but this level of attacks is just on a totally different level. most importantly, we in the United States are supporting. Malnutrition, destruction of the wash infrastructure, and overcrowding have made surgical success basically impossible. It's actually almost kind of silly to talk about. The hospitals in Gaza used to be displaced persons camps. I'm guessing when we were at Shiva, it was probably the same. When I was at European hospital, she's interesting. It was also a DP camp, and it basically made it impossible for the hospital to function. Now all the hospitals in Gaza have said, no, we're not going to allow people to come into the hospital and shelter here, but it's, you know, there's been nothing has actually entered the Gaza Strip since March 2nd. All of the northern hospitals are out of anesthesia, they're out of surgical supplies, and Nasser, which right now is functionally the largest hospital in Gaza, will soon be out of medical supplies as well. And finally, it was possible to provide advanced care in this very resource-poor setting at the individual level, but not at the massive level that is needed. And trauma is basically a massive public health problem in Gaza, in addition to all the other massive public health problems: lack of food, lack of water, lack of sanitation, lack of hygiene, lack of a sewage system, lack of education, lack of, et cetera, et cetera. So these are major problems that surgery certainly can't solve, but at least by being aware of them, maybe we can.
Thanks so much. Next, we're going to invite Dr. Heider, who's a MPH candidate at Columbia University, to present epidemiology of disease outbreak during military conflict.
Hi, my name is Sarah. I'm an FICS candidate at Columbia University, but everything we're going to be talking about today is all research that I conducted independently. I do not represent my institution right now. So I'm going to be talking about the epidemiology of disease outbreak during military conflict. But firstly, I want to introduce you guys to Paul. He was only 6 years old when he first contracted polio after a day of play in Dallas. And he contracted it only 3 years after the vaccine was declared safe and effective, paralyzing his entire respiratory system and making him reliant on an iron lung to breathe for the rest of his life. And he just passed away last year after contracting COVID. And today, he is known as the last man who lived in an iron lung. So this picture on the left is our cases of all these children who had polio, and then the one on the right is back in New York when there was a huge polio epidemic, and that's how they were treating everybody with a bunch of iron lungs that they had available. So here is a chart of just some humanitarian catastrophes, famines. That was, and all this data is from the IPC. And they are, the severity is measured by the percent population in the IPC of 5, which is the worst hit location, and then the x-axis of the magnitude is measured by the total number in IPC 5 across the whole country or territory. And so, as you can see, Yemen is all the way in the bottom, and because this was conducted in 2024, they were able to see that Gaza had, just the entire strip was the most in 2024, and then even worse in the north. And so the IPC is, what they do is just typically identify famine conditions and inform response to save millions of lives, and rarely do they ever send out alerts. And so they did for Gaza, and that just goes to show how there is so much starvation, malnutrition, and excess mortality due to malnutrition. And Alex DeWall said that this is from his study, and he always says that famine is always man-made. And so I did some more research to see how much aid was going into Gaza, and I found that there were 2 different reports, one from the Israeli side and then one from the United Nations. and I put them in a chart to see and compare the numbers. And the blue line is the results that COGAT had, and the dashed green was the United Nations. And this is only up until 2025, assuming that this probably works now. So here is, to put it into context of the wash situation, this entire, the orange area is the entire coastal basin, which supplies 90% of the region's water. And according to a 2020 study, it's also by the Israeli Information Center of Human Rights in the occupied territories. It's also polluted by untreated water, leaving 96.2% of household water from the aquifer undrinkable. And as a result, 97 of Gazans rely on unregulated tidal water tankers and sometimes solar-powered desalination plants for drinking water, according to the World Bank. And so in this picture, the three orange squares are the major desalination plants, and they have all been seized now because of the blockade, and that left the smaller blue squares as the smaller desalination operations, but the quality of water treatment in those plants are still spotty. And to put it into perspective, in a 2021 study, 79% of the desalination plants in Gaza were unlicensed, and an average of 12% of desalination water samples tested to show serious, dangerous levels of contamination. And so if in 2020, 96.2% of water is undrinkable, the percentage has definitely increased due to the blockade and the siege since 2023. And in 2024, June, water and sanitation was officially declared collapsed and almost entirely defunct. And the only remaining clean source of water was the rain, but that is now prohibited due to life. So in this top chart, it was the World Health Organization data from 2020, and everyone was able to access 83.1 liters of water. Now, in the chart below, the water supply is critically insufficient, and each person only getting 1.5 to 1.8%, according to the World Health Organization, and the emergency minimum by the World Health Organization is 15%, which is already far lower than the average recommended of 100 liters. And so, although global polio cases have decreased since 1988 by 99%, the World Health Organization detected polio type 2 in the sewage waters between communists and Dearborn in December of 2023, implying that it could have been there since September of 2023. And this is the first case that they saw of Abdul Rahman, who's a 10-month-old, where they found it they detected it in August of 2024, and 1 week later, the World Health Organization announced the detection of polio. Or 1 week after they did, the Gazans Health Ministry declared that there was a polio epidemic. And so they went in. It was collaborative efforts of the World Health Organization, UNICEF, and local health authorities who collaborated together and set up campaigns to give oral vaccines during, it was September 24, November 2024, and February 2025. And on the opposite end, all the soldiers working in the region were also given boosters. This just goes to show and highlight how urgent it is, because as long as one child is who carries the virus, it endangers children everywhere because there's no cure. There's a missing slide, so that's okay. But I conducted an interview with the best friend of Paul, going back to the first guy that I talked about, to question his thoughts about the recent outbreak. And he said polio was the worst thing. He hated polio is the thing that he hated most in this world. I never seen him speak any more passionately than when he talked about eradication of polio. And for him, the thought of one more person getting it was heartbreaking. He could focus on the numbers, whether it was 100 or 1,000 people who would be devastated by the thought of just one more child or person suffering from it. And outrage would have been, in his mind, the worst possible thing that could ever happen. And in his book, 3 Minutes for a Dog, comes from a promise of one of his caretakers that they made, that if he could breathe on his own for just 3 minutes, that he'd be able to get a dog. And if there's a fortunate way to have polio, it would be how Paul experienced it. Living in the U.S., where he had his own personal iron lung, he was close to a hospital with another iron lung reserved just for him, access to 24/7 caretakers, tax relief, and government support. In Gaza, children with polio wouldn't live with it the way that Paul did; they would just die. I don't think people fully grasp that they would be able to fly in iron lungs, and it's just a death sentence. I'm happy that Paul isn't here to be witnessing in Gaza what's happening in Gaza, because I believe it would have broken him. For him, it wouldn't have been a political issue; it would have been about speaking out about humanity. Paul was my friend, and I know how he would have reacted. While I can't speak for him, I believe my experiences with him gave me a good sense of how he would have felt about all this. He would say that everyone needs to stop what they're doing and address this issue immediately. He was a strong advocate for peace and wanted everyone to get along. It's easy to ignore what's happening to people far away, especially if it's a disease that hasn't touched your lives or your children's lives. But for him, it was very real and very personal. I saw firsthand how crippling this disease can be, and no one deserves to endure it. The children of Gaza have done nothing but be born in a situation beyond their control, yet they're the ones suffering the most. And so later he talked about in his book, Paul describes that his diagnosis was a rush of death that made him fear the future, and for him breathing was as difficult as for us breathing underwater. His story stands as a testament to the devastating impact of polio, emphasizing the paramount necessity of vaccine distribution to prevent such suffering. In the Gaza's health ministry had called for media intervention to end the aggression, which is not only critical to address the significant health threat to Gaza's residents, but also to prevent the epidemic from spreading in neighboring countries. And so the water sources can be seen in these examples where the tents, where everyone lives, is right next to the water supply and even under the tents as well. And that's where they pee, they drink, they sleep on, and those are all the cases that are in Gaza right now. And so the ongoing year-long, now longer, have already stained public health resources, making living conditions even more dire, and humanitarian need is at a climax to save innocent lives like Paul and Gaza.
Thank you. Next, we'll invite the podium Kathleen Campos from the state of Washington. She's a global health and surgery trainee who is speaking to us about the strengthening trauma during crisis, advancing emergency surgical response, and capacity building through targeted training in austere practice.
Good morning. Thank you very much for your presence here today. I will be presenting Strengthening Trauma Care in Crisis, Advancing Emergency Surgical Response and Capacity Building through Targeted Training in Austere Environments. I have no disclosures. In war and disaster trauma surgery, survival is measured in seconds, yet definitive access to care remains unpredictable. In 2025, over 305 million people in 72 countries require humanitarian aid, with 120 active armed conflicts worldwide. Civilians now account for up to 90% of wartime casualties. And as conflicts evolve and mass casualties increase, specialized trauma training is more critical than ever. To drive meaningful change, we must first identify gaps, recognize effective strategies, and act decisively. For decades, the golden hour principle has underscored trauma care. However, in modern conflict zones, this standard is often unattainable. Prolonged evacuation times, overwhelmed medical facilities, and stretched field hospitals continue to delay life-saving interventions with severe consequences. We've seen this throughout the talks this evening. For example, in the Iraq and Afghanistan conflicts, 87% of combat-related deaths occurred before reaching a medical facility. This highlights an urgent need to rethink how we train, deploy, and equip trauma teams and local healthcare teams in crisis settings. Key barriers to effective surgical care in conflict and disaster settings include logistical challenges, resource constraints, insufficient integration of local training programs, and a lack of standardized context-based trauma care models. For example, a recent assessment found that only 66% of military surgical trainees felt ready to deploy, and even fewer felt confident managing complex trauma. While this data focuses on military trainees, similar gaps exist among civilian and humanitarian actors who often face the same challenges with even fewer resources. Strengthening surgical care in a humanitarian context requires practical, adaptable, and sustainable solutions. Standardized training models, improved coordination in high-risk areas, and better resource allocation for local teams are essential. To evaluate the impact of existing approaches, we conducted a systemic review. 32 reports met inclusion highlighting both critical gaps and successful interventions that have been applied in the field. 4 primary themes were identified, including the role of local healthcare workers in trauma response, the necessity of civil-military integration, the impact of telemedicine and remote mentorship, and the importance of global health security programming in surgical response. In high-stress environments, the right training at the right time can be the difference between life and death. Structured programs for emergency medical teams, EMTs, and specialized training in damage control surgery are pivotal in enhancing preparedness and effectiveness in crisis situations. A notable example is the Teams 3.0 training package. A retrospective 2023 study by Kane and researchers evaluated this program across Portugal, Germany, Norway, and Turkey, showing a 27% increase in self-efficacy and a 32% improvement in teamwork performance among 100 participants. These findings highlight the program's effectiveness in enhancing confidence, coordination, and communication in disaster response among trauma teams. Similarly, the damage control surgery ICS training platform evaluated in 2022 for a prospective interventional study by Tu and colleagues demonstrated a significant impact in military and civilian conflict settings. The study found that live tissue DCS training led to a 35% improvement in surgical response times, a 28% reduction in complication rates, and a drop in mortality from 46% to 18% through enhanced hemorrhage control and early resuscitation. This highlights the critical role of DCS training in improving outcomes in mass casualty and resource-limited settings. Our review found that 75% of reports advocated for stronger collaboration between military and civilian trauma care teams, reinforcing the necessity of integrated training, coordination, and operational models. Collaboration between military and civilian medical services has been shown to improve trauma care outcomes in conflict and disaster contexts. One of the most significant findings in recent research is the improvement in surgical outcomes when civil-military cooperation is well coordinated. A 2020 retrospective study by Howard and colleagues found that collaboration between military and civilian trauma teams during the Afghanistan and Iraq conflicts reduced preventable deaths by 15%, with the 44% of this improvement being due to better pre-hospital care and transport coordination. Similarly, a retrospective analysis by surgeon researchers found that joint military-civilian operations in Iraq between 2001 and 2011 reduced traumatic injury mortality by 25%, underscoring the impact of integrated response systems. Further reinforcing the importance of civil-military coordination, the 2022 global case series by Al-Sawadi and colleagues examined integrated trauma systems worldwide. The study highlighted that strong government support and structured collaboration between military and civilian teams improved patient outcomes, while financial constraints remain a key barrier. These findings emphasize the need for sustained partnerships to strengthen trauma care in crisis settings. Technology is transforming trauma care, breaking down barriers and enabling real-time expertise across borders. In conflict zones where surgical specialists are scarce, telemedicine and remote consultation have become lifelines for frontline providers. These realities underscore the urgent need to invest in telehealth infrastructure, support real-time surgical mentorship and consultation, and foster innovation and knowledge exchange that connects providers across civilian, military, and humanitarian systems, strengthening care where it's needed most. For instance, Parks and team in 2022 examined telemedicine interventions across 6 conflict-affected countries in the FICS, Eastern Mediterranean region. The study found that telemedicine is not only feasible using low-cost, accessible technologies to bring specialized surgical expertise to areas where medical resources are critically limited. Additionally, a 2024 prospective study by Andrea and colleagues focused on virtual emergency medical training in conflict zones using case studies from Ukraine and Sudan. Their findings were significant. A 40% increase in the local workforce capacity to manage trauma cases was noted, and a 20% reduction in patient referral times to specialized care facilities was highlighted in their study findings. These results prove that technology is not only just filling gaps, it is transforming surgical response programming and enhancing expert surgical decision-making, accessibility, and knowledge exchange, even in the most challenging environments. The fourth key insight to emphasize is the critical need for global health security activities that integrate surgical response and trauma system operation efforts that are most effective when grounded in local realities and strengthened through carefully selected medical, civil, military coordination. This integration is essential for effectively managing, mitigating, preventing, and responding to attacks on healthcare while fortifying health access. To illustrate, a 2020 study by Garber and colleagues demonstrated that positioning trauma stabilization points near the front lines during the Battle of Mosul improved access to timely surgical care, underscoring the importance of aligning military logistics with civilian healthcare to enhance crisis response and strengthening of local healthcare systems. Another strong case in point is a 2024 scoping review by Baird and team on the global assessment of military and civilian trauma teams integration. The review identified 5 key civil trauma integration domains, with 45% involving academic collaboration efforts. It showed that logistical coordination significantly improved civilian healthcare efficacy and trauma outcomes, with administrative report emerging as the most critical factor for success and its barrier being the greatest. Together, these findings demonstrate that advancing global health security in conflict settings depends on purposeful collaboration, strong leadership, and coordinated logistics to enable responsive healthcare delivery. The impact of these collaborations is undeniable. The Kandahar NATO Role 3 Medical Unit brought together military personnel from multiple countries, civilian trauma surgeons, and Afghan clinicians. A result, a 30% increase in survival rates for critically injured patients. This is a testament to the power of integrated trauma. Apologies, I lost the mouse. Let me just set. Okay. Other examples include the WHO Signals EMT Work Group, established in 2017 to enhance humanitarian medical response operations. This initiative has set global standards that have since improved trauma care in major humanitarian emergencies, including the Regina refugee crisis, various national disasters such as the Syria-Turkey earthquake, and protracted conflicts in Palestine, Sudan, and Ukraine. These examples reinforce a clear message. When military and civilian teams work together, lives are saved, trauma systems are strengthened, and global health security is fortified. In conclusion, strengthening trauma care in austere environments demands sustained commitment to advancing emergency surgical response, expanding access, and investing in locally driven training, knowledge exchange, and capacity building efforts. Trauma is not an isolated event, and our response cannot be either. It must be coordinated, sustained, and global. Wars won't wait, disasters won't pause. The next mass casualty event is coming, it's here. The evidence is clear. We cannot wait. Now is the time to act. Thank you.
Thank you very much. At the suggestion of the president, we're going to forego the talk of Dr. Perlmutter since time is up. If you have an interest in listening to that lecture, I'm sure that we can make available to you. At this time, we have time for one or two questions to any of the presenters, and then after that, we'll have